my name is Dr. Melissa Mateos. I'm a PGY2 resident at Palmetto General Hospital. I'll be presenting a case with the title of STEMI Alert, a terrifying case of spontaneous coronary artery dissection, or SCAD. SCAD is a dissection of a coronary artery not secondary to trauma, atherosclerosis, or iatrogenic causes, is a rare cause of acute coronary syndrome and predicted to occur in 0.1 to 4% of cases of ACS. Here we present the case of a 37-year-old male with SCAD. A 37-year-old male with past medical history of marijuana and tobacco abuse presented to the emergency room due to non-subsiding chest pain that occurred for 1 day. The pain was precipitated by extraneous exertion. He denies any similar episodes in the past, any known heart conditions, or any family history of early MI. He had initially presented at a non-PCI capable facility where EKG demonstrated slight diffuse J point and ST segment elevation on multiple leads. Echocardiogram showed an estimated EF of 45 to 50% without wall motion abnormalities, and multiple troponins were elevated with a peak of 7.590. Patient was medically treated for STEMI and immediately transferred to our PCI-capable facility where he underwent a left cardiac cath. Findings were significant for spontaneous coronary artery dissection at the distal aspect of the left anterior descending artery, with no angiographic evidence of obstructive disease. Given cardiac catheterization findings, patient was medically managed with dual antiplatelet therapy and statin given his hyperlipidemia. SCAD is a commonly forgotten diagnosis in young patients who present with ACS. Incidence is higher in patients younger than 50 years of age and has a higher prevalence in females compared to male subjects, 25 versus 10 to 50% respectively. Pathophysiology involves an intimal tear or spontaneous bleeding of the vasa vasorum with creation of a pressure-driven expanding hematoma which leads to luminal narrowing and subsequent myocardial ischemia. Risk factors include history of fibromuscular dysplasia, arteriopathies, pregnancy and early postpartum, multiplicity, increased physiological hemodynamic stress, coronary artery tortuosity, connective tissue disorders, systemic inflammatory conditions, hormonal therapy, emotional stress, intense Valsalva type activities, and recreational drug uses. In 20% of cases of SCAD, it is found to be idiopathic. Diagnosis can be performed by cardiac cath, CTA, cardiac MRI, IVUS, or like this patient, coronary angiography. Conservative medical therapy with long-term aspirin, beta blockers, or short-term clopidogrel or ticagrelor, and statin is a preferred modality of treatment. Percutaneous coronary intervention, or PCI, may be challenging in a friable vessel given the risk of occlusion due to a false lumen, risk of further dissection as well. Alternative treatment options include coronary artery bypass grafting or CABG, fibrinolytic therapy with or without subsequent PCI, mechanical hemodynamic support, or cardiac transplantation. Unfortunately, there is a high risk of recurrence after diagnosis of SCAD, therefore a close follow-up is required. Thank you very much.